Good evening, everyone, and welcome to this recall session on forensic medicine. And I am Dr. Suraj, and I am the tutor for forensic medicine in Dr. Polaris. So, what we are going to do in this session is we are going to discuss certain uh, very fertile areas for questions for your upcoming exams by the means of some MCQs. So these are not your conventional MCQs. These MCQs have been designed so that it brings forth a discussion, and we have chosen such topics from which the questions are most likely to come. So, uh, are we clear? Can you hear me? If you, when I ask you any question, you can answer through the chat box. So make full use of the chat box, and let me you know get a feedback from you through the chat box. Let me know whether you're hearing. So did you get the entire idea behind this recall session, dear students? So we'll begin with some questions from agricultural poisons topic, because I firmly believe uh, OP poisoning is a very important topic, and before you enter the exam hall, make sure you are thorough with the signs and symptoms, the mechanism of action of OP poisoning, the signs and symptoms, as well as the treatment of OP poisoning. So let's look at this question here. All of you read the question. So what do you think is right here? What are the right options here? What is the mechanism of action of OP compound? Does it cause accumulation of acetylcholine at the synapse? Does it paralyze the transmission? Does it bind to the active site and phosphorylate the serine moiety? Does it cause rapid degradation, making acetylcholine esterase enzyme inactive? Uh, and when the alkyl group is lost, does the compound become permanently inactive? So what do you think? Out of these five statements that you see, which is the right statement? I want to remind you that there can be more than one right option. This has been designed for the ease of discussion. So I would like the participants to answer through the chat box, and I'm waiting for your response. Come on. Make an attempt. Come on. I see there are at least 5 to 6 participants here. A and C are the right options. D is the right option. Any more answers? We are looking at the right statements. Out of these five statements, which statement is correct? It could be more than one. Could you unmute Kumar Yadav? Kumar Yadav, why did you select the option D? Kumar? Okay. Anybody else who would like to answer? Nobody? Okay. See, A is the right answer. Accumulation, there is accumulation of acetylcholine at the synapse, and there will be paralysis of transmission. So even B is the right answer. So the OP compound binds to the active site of acetylcholinesterase enzyme and phosphorylates the serine moiety. So once the enzyme and the OP complex they bind, what happens is there will be slow degradation, which makes acetylcholinesterase enzyme inactive. It is not rapid degradation. There will be very slow degradation, making acetylcholinesterase enzyme inactive. And once the alkyl group is lost from this OP and the enzyme complex, the enzyme becomes permanently inactivated. So it cannot be reactivated after that. So here the right statements are A, that is accumulation of acetylcholine at the synapse, paralysis of transmission, it binds to active site and phosphorylates serine moiety, and alkyl group is lost and becomes permanently inactivated. So A, B, C, and E are the correct options here. Now, all of you remember when we talk about the signs and symptoms of OP poisoning, we generally classify that into the signs of or the muscarinic features, the nicotinic features, and the CNS features, because the OP compound tends to cross the blood-brain barrier. So, what are the muscarinic features of OP poisoning? What does it include? Out of these options, A, B, C, D, E, and F, what are the features of OP poisoning? The muscarinic features of OP poisoning. Or let's make it simple. Which among these is not the muscarinic feature of OP poisoning? Out of the 6 options that you, which among these is not the muscarinic feature of OP poisoning? Come on, participants. Yes, F. F is muscle paralysis. Muscle paralysis is not a muscarinic feature. It is a feature of, it's a nicotinic feature. Okay. So can anyone here recall the mnemonic for muscarinic features? Anyone? You can type it in the chat box. Sludge. There's one more easier one, which is yes, dumbbells. You can see here diarrhea, urination, meiosis, bradycardia, bronchoconstriction and bronchosecretion, and lacrimation. These are the features of the muscarinic features of OP poisoning. And muscle paralysis is a nicotinic feature. So let's proceed. So what are the nicotinic features of OP poisoning? Which among these are nicotinic features of OP poisoning? Once you have seen the answer for the previous one, this should be easy. All except A. Very good. All except A. Because bradycardia is a muscarinic feature, and in fact, because of the nicotinic receptors, what you see is tachycardia. There is increased blood pressure and increased heart rate because of the activation of the nicotinic, because of the blockade of the nicotinic receptors. Okay. So bradycardia is a muscarinic feature. So the odd man out here would be bradycardia, and all except A are the features of nicotinic features of OP poisoning. So are we clear? Shall we proceed? So coming to the treatment of OP poisoning. Treatment of OP poisoning includes all of these except one, which is that which among these is not used in the treatment of OP poisoning. E. So everything else that you see, that is atropine, is used in the treatment of OP poisoning. It's a specific antidote. Then there is pralidoxime and obidoxime. These are oximes. Oximes are the reactivators of the enzyme. So oximes are used. Then as supportive measures, we can try antibiotics. Then decontamination of skin and eyes can be done through irrigation, and stomach wash with potassium permanganate and use of activated charcoal is actually advised. And of course, oxygenation, intubation, and positive airway ventilation is required in treatment of OP poisoning. What you do not require is succinylcholine. So I believe all of you are well versed with the management of OP poisoning. And I want to repeat again that OP poisoning is one question which keeps repeating in question papers. So usually it comes as a 10 marker, and it's very easy. You just need to write the mechanism of action. You just need to write the clinical features. And when you write the clinical features, you need to classify it into the muscarinic, nicotinic, and CNS features, and then the management of OP poisoning and the treatment of OP poisoning, which includes all of these that you see on the screen right now, except for succinylcholine. So are we clear? Are we clear here? Yeah. Okay, before I go into this question, what is the use of zinc phosphide? I would like to ask the audience, what is the use of zinc phosphide? Because nowadays, since the CBME has started, uh, there is a trend where a clinical scenario is given, and they might not directly ask you the features of zinc phosphide poisoning. Instead, they will give you a scenario where, as somebody has rightly pointed out, yes, zinc phosphide is a rodenticide. So there, the question might come with a clinical scenario where a person has consumed unknown rat poison, and the features would have been described. So based on that, you will have to arrive at the differential diagnosis, and then based on that, they might ask you the treatment. So it is very important for us to understand that zinc phosphide is used as a rodenticide. So what is the mechanism of action of zinc phosphide? The phosphide liberates phosphine gas, which is known to be toxic, and it liberates phosphine gas when it comes in contact with air and moisture. So that is why the stomach wash is contraindicated. Forget stomach wash. When a patient has consumed zinc phosphide, if he feels thirsty, uh, we are not supposed to give that patient water. So we need to avoid water, because once the water gets into the stomach, it will react with the zinc phosphide and liberate phosphine gas, and this phosphine can cause multi-organ dysfunction and it can cause death. So the zinc phosphide liberates phosphine. Yes, that is the right option. It has a metallic taste. It causes vomiting. It gives rise to garlicky odor. There is intense thirst. And even though the patient is feeling thirsty, we are not supposed to give water, because that could be detrimental because of release of phosphine gas. We can try activated charcoal with sorbitol, and IV dopamine can be given. And one bedside test that we use is the silver nitrate test, where a filter paper impregnated with silver nitrate is kept near the mouth and nose of the patient, and if it turns black, then that is indicative of phosphide poisoning. So the silver nitrate test is not only for zinc phosphide, it is true even for aluminum phosphide poisoning. Are we clear here? The silver nitrate test is not just for zinc phosphide, it is both for zinc phosphide as well as aluminum phosphide. Aluminum phosphide, what is the use of aluminum phosphide? Anybody here? What is the use of aluminum phosphide? Zinc phosphide, as you said, is a rodenticide. Nobody? Aluminum phosphide is a grain preservative. It's used in granaries as grain preservative. So, shall we proceed to the next topic? Next topic is drowning. So, classification of drowning includes, amongst the given 5 options, what does the classification of drowning include? Or what is the odd man out here? Let's make it simple. Which is the odd man out here? E, very good, Fatima. That is, partial drowning is not a type of drowning. You're right. So, no. D is in fact a type of drowning. Partial drowning is the odd man out here. A, B, C, D are, that is wet drowning, dry drowning, secondary drowning, and immersion syndrome. These are different types of drowning. So what is the other name for wet drowning? Anyone here? You can type it in the chat box. What is wet drowning also called as? Wet drowning is also called as primary drowning. Okay, wet drowning is also called as primary drowning. Moving on to the next one. What is immersion syndrome? So what does immersion syndrome include? Is there submersion inhibition or hydrofusion? Is it also called as submersion inhibition or hydrofusion? Or is a death due to hemoconcentration and hypovolemia? Is that a true statement? Cold water stimulates the nerve ending of the surface of the body. Is that a true statement? Water strikes the epigastrium and cold water enters the eardrums, nasal passages, pharynx or larynx. Which among this is not? Yes. Hemoconcentration is wrong. Can you explain, Fatima? Can you unmute yourself and let me know why do you say hemoconcentration is wrong here? Okay. Anybody else? Siva? No? Because what happens in immersion syndrome is the water does not enter the lungs. So as far as the water does not enter the lungs, there is no question of hemoconcentration, there is no question of hypovolemia. So immersion syndrome is where the cold water stimulates the nerve endings of the surface of the body, and death is, it could be usually due to cardiac arrest because of vagal inhibition, because of the water striking the epigastrium, or the cold water that enters the eardrums or the nasal passages the pharynx or larynx. So there won't be any hemoconcentration, hypovolemia in immersion syndrome because the water does not enter the lungs here. Coming to the next question, pathophysiology of drowning includes all except which among these is not seen in case of drowning? Please, anybody in the chat box? What is the odd man out here? Make an attempt. It's okay. It's okay if you're wrong. No problem. Yes, Siva, option B. You're right. Option B is the odd man out here. Everything else we do see in drowning. So what should have been instead of hypokalemia? What do you think should have been the right answer, Siva? If you don't want to unmute yourself, you can always type in the chat box. Anyone? Instead of hypokalemia, what it should have been? Yes, it should have been hyperkalemia. You're right. Because there is breakdown of RBCs because, that can lead to hyperkalemia in drowning. Okay, so hyperkalemia is the answer that we should be looking for. Hypokalemia is the odd man out here. What we actually see is hyperkalemia. You're right. So post-mortem signs of drowning are all except. There could be more than one right answer. So read the question properly. It just says postmortem signs of drowning. It's not specifying the signs of postmortem or antemortem drowning. So it just says postmortem signs of drowning. Yes, all points except rigor mortis. You're right. Now, let me reframe this question. The same options, but let me reframe this question. Listen to me carefully. What are the signs of antemortem drowning? Amongst these, what are the signs of antemortem drowning? The options are same. The question is different. The question is, what are the signs of antemortem drowning? Or what are the postmortem signs of antemortem drowning? Take your time, but I want you to attempt this. Nobody? Should I repeat the question? Do you want me to repeat the question? At least yes or no? Yes, E is the right option. Uh, yes. Other than that, anything else which is a sign of ante-mortem drowning? When it comes to ante-mortem drowning, the option E would be the right option, and froth again, that is the option C, would be right. I'll tell you. Cutest anserina, that is option D, and washerwoman's hand, that is option F. These can be seen even in case of post-mortem drowning. So these are non-specific signs of drowning. So these signs, that is cutis anserina, that is uh, the goose skin appearance, and the washerwoman hand, that is the bleaching, thickening, soddening of the fingertips, that is seen even in post-mortem drowning. So these are not signs of ante-mortem drowning. Whereas froth can be formed only in ante-mortem drowning, and uh, the grasping of gravel or leaves, etc. Again, these are the signs of ante-mortem drowning. Rigor mortis will appear early. It will not appear late. It will appear early in cases of drowning. And postmortem lividity, being light pink in color, is not exactly a clinching diagnosis. So I hope that was clear. Anybody has any doubts here? What I need you to understand is cutis anserina and washerwoman's hand are not the signs of ante-mortem drowning. They're just the signs of immersion. That is, it just means that the body was in water. It doesn't say that the death was ante-mortem drowning or because of something else. Whereas froth is indicative of ante-mortem drowning, and even the cadaveric spasm with some gravel or leaves, etc., from the water body itself is indicative of ante-mortem drowning. Hopefully, I'm clear about that. Now, coming to the test for drowning, which among these are the test for drowning, or which among these is not a test for drowning? That way, it would be easier. Right. We do not compare the serum potassium from right and left heart in case of drowning. We do that for chloride, which is called as the Gettler's test. Then we compare the plasma specific gravity, uh, the magnesium and the strontium content, and also the diatoms test. These are the various tests for drowning, but not serum potassium. Moving on to another topic, mechanical asphyxia. So, mechanical asphyxia is a very important topic, and we have seen time and again question appearing from this topic, that is mechanical asphyxia. Usually, what we get to see as a 10 marker is the classification of hanging. What are the types of hanging, and then the postmortem signs of hanging, and these are the kind of questions that we regularly get to see. And sometimes we get add-on note, like we get a 10 marker where they ask the types of hanging and the postmortem signs of hanging, and you add a note on the different types of hyoid bone fracture. So let's start. Common methods of homicidal strangulation includes all except. It's a very straightforward question. Yeah. Other of course, hanging is hanging. Hanging is not strangulation. Rest everything are different variants of strangulation. There could be strangulation by ligature, or there could be manual strangulation, which is also called as throttling. There is palmar strangulation, and there is garroting and mugging, which are variants of strangulation. A pretty straightforward question. So the postmortem appearance in strangulation are all except. Which among these is not a postmortem sign of strangulation? Take your time. Yeah. Yes, the answer is E. That is dribbling from mouth over chin or chest. Where do you see dribbling from mouth over chin or chest? What is that a feature of? Dribbling from mouth over chin or chest is a classical antemortem sign of something. What is that? Where would you get to see this E? Yeah, it's a sign of antemortem hanging. Dribbling from the mouth over chin or chest is a antemortem sign of hanging. The rest, whatever you see, the ligature mark can be seen even in cases of hanging. Petechial hemorrhages can be seen in cases of hanging. Intense congestion and deep cyanosis. This is a very non-specific sign which may be seen in case of strangulation and some cases of hanging also. Eyes wide open, bulging and suffused is a case. It's a sign of strangulation. But dribbling from mouth over chin or chest is not seen in strangulation. It's only seen in cases of hanging. Are we clear here? Right. All are true about garroting, except what is the wrong statement here? Victim is attacked from behind without warning. Neck is grasped by a ligature thrown from behind. Ligature is tightened by twisting it with lever or two sticks tied at the end. Results in sudden loss of consciousness and collapse. Multiple assailants required to kill the victim. Right, right. You don't need multiple assailants. Garroting is something where a single assailant can incapacitate the victim. So all the other features are seen in garroting, and the one more important feature is that it requires single assailant. I'm not saying multiple assailants are not needed. I'm just saying even a single assailant can do garroting. Okay, I think that was kind of self-explanatory. Let's go to the next one. Manual strangulation. Asphyxia produced by compression of the neck by human hands is called as manual strangulation. The cause of death is occlusion of carotid arteries. Ball contusions are seen. Bruises are usually absent, and fractures of neck bones are absent. Which are the right options here? Out of these five options, yes, A, B, and C are the correct options. That means D and E are wrong options. So let's discuss on D and E more than A, B, C. Bruises are usually absent. That will be wrong. You will see extensive bruising when it comes to manual strangulation. And fractures of the neck bones. So what do you mean by neck bones? The thyroid cartilage or the hyoid bone. So these bones are commonly fractured in case of manual strangulation. And may I ask you one more question? What is the reason for ball contusions? What is the reason for ball contusions? Yeah, the pressure due to what? Yes, The ball contusions are because of the pressure being applied by the fingertips. Very good. Moving on to one more topic from toxicology, that is the metallic irritants. And just like I said, how important OP poisoning is for UG from the exam point of view, plumbism and saturnism, that is the and hydrargyrism. Plumbism, that is chronic lead poisoning, and hydrargyrism, that is chronic mercury poisoning. These two are very important questions from exam point of view. One or the other will usually appear in one of in your question paper. It could be either chronic mercury poisoning, it could be chronic lead poisoning. So it might not be, the question might not be straightforward. They might ask you, what is uh, plumbism? What is plumbism? Anyone here? What is plumbism? Lead poisoning, chronic lead poisoning. It's very specific. Chronic lead poisoning is plumbism, not acute lead poisoning. And what is hydrargyrism? Chronic mercury poisoning. Again, let me be very specific there. Chronic mercury poisoning is called as hydrargyrism. Okay, so let's start with the set of questions from metallic irritants. Out of these, which compound of arsenic is not known to be poisonous? Anyone? B, right, arsenocholine. All other options are known to be toxic compounds of arsenic, and arsenocholine is a biologically the naturally existing form of arsine in various uh, you know your organisms present in water. So take your time and read this the question and read out all the options. Clinical picture of acute poisoning of arsenic. I'm talking about acute poisoning of arsenic. So clinical picture of acute poisoning of arsenic. It resembles bacterial food poisoning. There is vomiting and abdominal pain. There is rice water stool. There is dysphagia, hepatic and fatty infiltration, and renal symptoms like oliguria and uremia. There is bilateral pedal edema and CNS features like peripheral neuropathy. So, which among these is the right option? Wrong option. There is no edema. Very good, Fatima. There is no edema. What do you see? What do you see instead of edema? What is the feature that you get to see? Yes. Yeah, hyperkeratosis of palms and soles, but that is a feature of chronic poisoning. There is something else that you see instead of your bilateral pedal edema. There is something else that you get to see. There is a blackening. There is gangrene of the foot. Okay, there is gangrene of the foot. So let's go to the next one. Now we are talking about the chronic arsenic poisoning. Which among these is not a feature of chronic arsenic poisoning? Very good again, Fatima. Other than use lines, everything else is a feature of chronic arsenic poisoning. Okay. So the lines that you see is the Aldrich-Mees lines. So since you have some two markers now, the question can appear as this. Write the dermatological manifestation of chronic arsenic poisoning. Then the answer would be raindrop pattern of skin pigmentation, hyperkeratosis of skin of the palms and soles, and Aldrich-Mees lines. These are the dermatological manifestations of chronic arsenic poisoning. Now, which among this is the wrong option? When it comes to management of chronic arsenic poisoning, which among these is the wrong option? B, USG abdomen. There is no need for ultrasound of abdomen. Instead of that, you can take abdominal X-ray, and that will show you what? What does the abdominal X-ray show? Anyone? What will you get to see in the if no, not air under the diaphragm. We'll see radio opacities when abdominal X-ray is taken. Anyway, well tried. Good, Salma. Okay, what is plumbism? Plumbism is chronic lead poisoning. So now go through these options and tell me which one is the odd man out here. What is not true? Yes, you see lead encephalopathy, but you do not. The encephalopathy is not hepatic in origin, so you don't get to see hepatic encephalopathy. The rest all the options are correct. Yes, rest all the options are correct. Right. So remember, when it comes to treatment of the, the metallic poisons like mercury, arsenic, and lead, the antidote, the chelating agent would be BAL. So I always keep telling BAL for MAL, that is British anti-lewisite for mercury, arsenic, and lead. Remember that BAL for MAL. Right. Acrodynia. What is acrodynia also called as? Anyone? Before we proceed, can someone tell me what is acrodynia also called as? Very good. Very good, Salma. Acrodynia is also called as pink disease, where you get to see pink, puffy, painful paresthetic peripheral paresthetic peripheries. And you see this in pediatric age group. Pink disease seen in children or seen in pediatric age group because idiosyncratic hypersensitive reaction. So what is it due to but mercury? Pink disease is because of exposure to mercury and not zinc. You're right. The odd man out here would be zinc. Rest all are the correct options. Any doubts here? Any doubts in this topic of metallic irritants? Please revise mercury, lead, and arsenic before entering your exam. Yes, sure, Salma. What's the doubt? Why is it called idiosyncratic? It's called it's a type of hypersensitive reaction, which is peculiar. It's not predictable. There is no particular reason for it. So it is peculiar to certain individuals. You do not get to see in everyone. That is why it is idiosyncrasy. You might have read about idiosyncrasy in your pharmacology, right? So this idiosyncrasy is uh, it's very peculiar. You don't get to see in everyone. You get to see in very few cases, and it is not predictable. So that is why it is called as idiosyncratic. So shall we proceed? Okay. Before I proceed, one more question. Where do you get to see Danbury's tremors? Very good. It is seen in chronic mercury poisoning. You get to see chronic mercury poisoning. You get to see these tremors, which is initially called as Danbury's tremors, and then it's also called as Hatter shakes. You might have heard of this. So this is a feature which is peculiar to mercury. Okay, let's move on to putrefaction. Post-mortem changes per se is important. It's an important topic, especially rigor mortis and post-mortem lividity. These are two very important topics, as well as mummification and adipose hair formation. So from this topic, make sure these four questions, that is rigor mortis, post-mortem lividity, mummification, and adipose hair formation, you have revised it thoroughly before entering the exam. Characteristic feature of putrefaction includes yes, all four options A, B, C, and D are right options. Okay, all four options are right options. So there is change in the color of the tissue, there is development of foul smelling gases, and there is distortion of the body. There is a liquefaction of tissue because of breakdown of the tissue, and there is a marbling. Marbling is seen in the superficial veins as branching pattern, and it's seen as early as 18 to 24 hours. So marbling can be a 2-mark question. Now, what is the first external sign of putrefaction? Is it marbling? Is it liquefaction of tissue? Is it greenish discoloration of the skin or the region of liver, or greenish discoloration of the skin or the region of cecum? Which among these is the first external sign of putrefaction? Yes, greenish discoloration. There are two options, but where? Yeah, over the region of cecum. Greenish discoloration of the region of cecum is the first external sign of putrefaction. So can you tell me what is the first internal sign of putrefaction, Salma? What would be the first internal sign of putrefaction? Not sure. It's okay. That would be the discoloration in the undersurface of the liver. Okay. The discoloration internally, undersurface of the liver is where you first see the discoloration. Is that clear, everyone? And why do we see the greenish discoloration of, the region over the cecum? That is because cecum is loaded with bacteria, and here what happens is uh, the fecal matter is in the fluid form, and that is why the bacterial load is highest in this region, and that is why the signs of putrefaction are first seen in this region. Okay, I hope that was clear. Easy. Now, what is true regarding post-mortem purge? Is it because of the presence of gas in the abdomen? Is it true that the diaphragm is forced upwards in case of post-mortem purge? Does it compress the liver and the intestine? Is there blood-stained froth exuding from the mouth and nostrils in case of post-mortem purge? Do subcutaneous tissues become emphysematous? What do you think is the right option? Or let's say, what is the wrong option here? What is the odd man out here? There are more than one right option. So what is the wrong option here? You are right. D is correct. The blood-stained froth exudes from the mouth and nostrils. So where does this blood-stained froth come from? It comes from the breakdown, that is liquefaction, and that is because of the option A, that is there is presence of gas in the abdomen, and this gas will push, okay, this gas will push the diaphragm upwards, and the breakdown of lungs and the heart is taking place, and that is why this fluid is pushed out from the uh, mouth and nostrils. So there is the compression of liver and intestine is the wrong option here. There is no compression of liver and intestine. In fact, the intestine will be distended. Okay. However, there will be compression because of the push from the diaphragm. There is compression of heart and lungs. Okay, and that can lead to the blood-stained froth being oozing out of the nostrils. Am I clear? So the odd man out here would be compression of liver and intestine. Instead of that, what you see is compression of heart and lungs. Conditions affecting the role of the rate of putrefaction. What do you think out of these are the conditions that alter the rate of putrefaction? Does temperature and moisture? Yeah, yeah. So Salma, I believe Salma was the one who answered this, right? Race and gender has got nothing to do with the rate of putrefaction. You are right. Temperature and moisture will affect. Clothing and manner of burial matters. Age and condition of the body matters. And cause of death will matter. That means if there is any open injury, then there is there is a portal of entry for the microorganisms, and that can increase the rate of putrefaction, and mutilation also increases the rate of putrefaction. Good. So complete this sentence. Dash rule or dash dictum states that a body decomposes in air twice as rapidly as in water and 8 times as rapidly as in earth. Yes, you are right again. The answer is Casper's dictum. Okay, Casper's dictum. So can I ask you, where does Nishten's rule appear? Anyone? In relation to what phenomena do you get to hear about Nishten's rule? Rigor mortis, March of rigor. Very good. Very good. And McNaughton's rule, anyone? Where do you get come across McNaughton's rule? In what topic? It's about criminal responsibility of insane person. McNaughton's rule you come across in forensic psychiatry with relation to criminal responsibility of insane person. And McNaughton's rule is the British version, and the Indian counterpart of that would be Section 84 of IPC. Adipose formation. So, what is wrong here with relation to adipose formation? Uh, it's not that there is no smell, there is smell. Adipose formation has a fruity smell. Okay, it's a fruity smell. It's not a foul smell. So rest all the options are correct. It's a modified type of putrefaction, and there is formation of soft, whitish, waxy, and greasy material in fact containing tissues of the dead body. And this is because of gradual hydrolysis and hydrogenation of pre-existing fats into higher fatty acids. So I'll always tell when it comes to adipose, you need to remember H and H, that is hydrolysis and hydrogenation of pre-existing fats into higher fatty acids. And there is a fruity smell, and the adipose is flammable and burns with faint yellow flame. So coming to medical legal importance of mummification, what is or what are the correct options here? B, estimation of time since death, right? D, found mixed with other forms of decomposition is also correct. Uh, Diagnosing cause of death is also right. Helps to establish identity. All four are correct options. Okay. All four here are correct options. There is no false statement here. Right. So just like I said, H and H for adipose formation, what would be what would be the alphabets that you need to remember in mummification? Anyone? Does anyone remember? It would be D and D. Mummification is D and D. That is dehydration and desiccation. Like you saw in case of adipose, there is hydrolysis and hydrogenation. You get to see dehydration and desiccation. Okay, or drying and desiccation. Remember this. It's just some easy way to memorize these. Okay. So shall we proceed with the thermal injuries? What is wrong here? It's kind of evident. What is wrong here? Yes, which one? Which value is wrong here? A. Yeah, that's kind of common sense, right? Anything above 35 can't be hypo. It has to be hyper, right? Right. So what should have been the right option? It should have been 35 to 32.2 degrees Celsius is mild hypothermia. Anything less than 32.2 up to 28 is moderate hypothermia. Anything less than 28 degrees Celsius is considered as severe hypothermia. Okay. So which among these is not a cause of death in hypothermia? Anyone? Can it cause ventricular fibrillation? Yes, there can be ventricular fibrillation. There can be DIC that could lead to acid-base imbalance. Hypothermia can cause bronchospasm. There can be pulmonary edema. However, shock is not known to occur in hypothermia. Okay, so the odd man out here would be shock. Autopsy findings in hypothermia are, which among these are the findings that you get to see in hypothermia? Temperature is more than 40 and above. Very good, Salman. All are correct options. It's a life-threatening medical emergency resulting from failure of the thermoregulatory mechanism. It's characterized by cerebral dysfunction with impaired consciousness and absence of sweating. And there are two forms, that is classic and exertional form. And the core body temperature, to call it heat stroke, will be anything above 40 degrees Celsius, not above 35 degrees Celsius. Okay, so that was about heat stroke. Now, what amongst these options are considered as delayed cause of death in births? Yeah, in hypothermia, that's seen. Correct. Autopsy finding of erythematous patches, that is because of this erythema is because of localized areas where there is no circulation, and that leads to these erythematous patches. There is complete breakdown of your heat thermoregulatory mechanism, and that can lead to okay. So if you I believe your exams are approaching. So what are those questions which you will definitely study before you enter the exam hall? You tell me. What do you think are some important questions? Drowning, that's a very vague topic, drowning. Let me be very specific. The pathophysiology of drowning and the signs and symptoms of drowning are important. The entire topic of drowning is a huge, vast chapter. So be specific. Again, when it comes to hanging, it's the types of hanging, the signs and symptoms of hanging, and the postmortem appearances of hanging. This is important. And the hyoid bone fracture. OP poisoning, mechanism of action, the signs and symptoms, and management. Good. OP poisoning is important. Drowning, certain aspects of it is important, and hanging. Especially when it comes to drowning, the pathophysiology of drowning, the flow chart which you need to draw, where you explain the seawater drowning and the freshwater drowning. That flow chart is very important. You're right. Anything else? Ballistics. Ballistics. See, ballistics is again it's a it's a vast it's a huge topic. So you could make sure that you read the peculiar ballistic effects. Okay, it could be duplex cartridge, it could be Rayleigh phenomena, it could be something like a dum-dum bullet, or it could be the sometimes there can be a question like autopsy in case of suspected firearm deaths. So then in that question you need to be very specific, like before we start autopsy we need to do a radiological examination of the body, then the examination of clothing, and then you proceed with the autopsy steps of autopsy. Okay, and how we retrieve the foreign bodies. We make sure that we do not introduce any scratches, so we need to use this rubber tip forceps. Be very specific and present your answer nicely. Okay, highlight the important points. Metallic poisoning, not the entire topic of metallic poisoning. What would be more important is chronic lead poisoning, chronic mercury poisoning, and maybe even arsenic poisoning to a certain extent. And the differences between arsenic poisoning and bacterial food poisoning is asked sometimes. So that is important. So ballistics is something that I would suggest you to study, as towards the end. Don't start with ballistics. Of course, you need to study the negligence, definition of negligence and definition of professional misconduct. Remember, professional misconduct is a conduct of a doctor which is regarded as disgraceful and dishonorable by the professional men of good repute and competence. Okay, the key word here is disgraceful and dishonorable. Okay, so you need to know the professional misconduct and various instances that of professional misconduct, which we popularly, which is referred to as 6 A's. Okay, 6 A's. And even the definition of negligence is important, and the ingredients of negligence, that is the 4 D's: duty, dereliction, direct causation, and damage. So these are some important aspects from medical negligence that you need to know. Res ipsa loquitur is very important. Please study res ipsa loquitur as well as vicarious liability. Okay, so these are the 4 important aspects from the medical ethics chapter. Anything else do you think that is important? Datura poisoning. When it comes to the toxicology, Datura is something that you should read. Chelating agents is something that you must read, and gastric lavage. Gastric lavage is again something that is repeatedly asked, and classification of poisons, as well as the legal and medical duties of doctor in a case of poisoning. And types of classification of mechanical injuries is something that is important. Classification of skull fractures is important. As Salma said, coup and contra coup injuries and whiplash injuries are asked repeatedly. Lucid interval is asked repeatedly, and cocaine bugs or magnan symptoms, that is tactile hallucination, is a two marker that you can expect. Narco analysis is a two marker that you can expect. Okay, I just given you some questions, and I'm very sure out of the topics that I mentioned in the past 2-3 minutes, at least 30 to 40% will be there amongst the topics that I mentioned in the last 2-3 minutes. Okay. Anyway, good luck for your exams. Hope this session has helped you, and I I I wish I hope that all of you will really do well in your exams. So that would be the end of my session, and thank you.